the second topic I'll be talking about is robotics in spine surgery, and again I have no financial disclosures. The objectives here are to review the use of robotics in spine surgery. We'll talk about the utility specifically in deformity surgery, which is one of my subspecialties, and then we'll talk about some of the enabling technologies such as doing single position surgery where you don't have to start prone or start lateral then go prone in order to place screws. We'll also talk about a transition in terms of moving towards minimally invasive deformity correction, which is something that's been very challenging historically. When most people think of the robot, they think about the Da Vinci, which is a surgeon's at a console and he's using the robot to perform surgery with haptic feedback. And this has been around for many years in many specialties, including cardiac surgery, urology, and many of the general surgery subspecialties. Well, the spine robot's very different in that there's no haptic feedback. What it really is it's very similar to the CNC robots that are used to manufacture cars and electronics that have been around for a while. They're very efficient, they perform a very specific task, and it does it precisely, it does it efficiently. And the robot in this context basically allows us to place screws in a very rapid fashion in under a minute, okay? The basis of any spinal fusion is rigid fixation through accurate placement of pedicle screws, and this has typically been done by hand. This is the way I trained, it's the way I've done it. But there are risks that come with placing these screws. Obviously, the perfect position for a pedicle screw is right down the pedicle in the midline where it terminates in the cancellous bone of the vertebral body. But if you're off axis in the thoracic spine, it can cause lung injuries. If you're too ventral, it can predispose to great vessel injuries. And if you're too medial, it can injure neural structures. The robot basically represents an attempt to automate the process of screw placement. That's really all it is. And there's 3 steps that are involved. Basically, the patient gets a preoperative CT scan, and you take intraoperative fluoroscopy images and merge those with the CT scan to allow you to essentially use segmentation rather than navigation to place the screws. So 3 steps, the robot arm comes in, you use a high-speed drill to create a tract, and you dilate over that tract in preparation for the pedicle screw placement. So what does this look like in real life? Essentially, the robot arm comes in and it homes into the area. We've already attached the robot to the patient. We've registered it to the preoperative CT. We use a high-speed drill to create that tract, and then we come in with a tap to basically dilate the tract in preparation for the pedicle screw. And then the final step in that process is really screw placement. And once that's done, the robot moves on to the next step. And so in a multi-level segmented fusion where you have upwards of 20 screws to place, it can be very daunting, especially if you have an assistant who's not trained to do the contralateral side. So here, this video sequence is about a minute, and you can see the screw goes in. You can appreciate on the screen behind me, which is sort of difficult to see here, but the pedicle screw ends up exactly where you want it to. And that process is very efficient, it's precise, and the likelihood for needing to revise a screw is very, very low. Since I've been using it, those numbers are single digits in hundreds of screws. So there's a lot of data out there saying that robot-assisted spine surgery is significantly beneficial. It increases screw accuracy for one, it decreases blood loss, it decreases the length of stay from an operative standpoint for patients, it decreases the need for a reoperation because of a malpositioned screw or because of instrumentation failure, because the instrumentation goes on to fail or the construct goes on to fail. It also decreases radiation. There's a lot of studies out there. One says it decreases radiation by about 80% to the surgeon and to the other staff in the operating room. And obviously the initial cost to establishing the robot is high, but once you've mastered it and you've overcome the learning curve, it shows that the number of revision surgeries that need to be done and the benefit from the decreased length of stay is substantially higher, and so cost ultimately is actually cheaper. So why robotics? Well, complex anatomy is made easy, and we'll go through a couple of cases that highlight that. It's also very efficient in my practice to be able to get through these long construct surgeries in a single sitting. It's reproducible. Humans obviously will fatigue over the course of a long deformity case, whereas the robots do not. It allows for optimal screw placement and alignment. There's increased patient safety, as I've shown before, and it enables single position surgery. Meaning, if you're doing a lateral stage, you don't need to reposition into the prone position. You can simply place the screws while the patient's in the lateral position, and we'll go through what that really looks like. It also enables minimally invasive deformity correction, something that's historically been very challenging for us. and obviously decreased stress reduction in terms of the surgeon. If I have to do a big deformity, the basis of the correction is dependent on those pedicle screws, and once they start to fail or pull out intraoperatively, you're done. Whatever correction you've gotten is what you'll have to take. So here's a case, scoliosis. We know that with scoliosis, the pedicle that tends to be the most diminutive is the concave pedicle at the apex of the curve. In this case, it's T8 and T9. Well, with the robot, you can input the software or input the patient's scans into the software, and every screw basically becomes fair game. It doesn't matter how small that pedicle is, it will place the screw exactly where you want it to. Ultimately, if you're also looking for a juxtapedicular screw because the pedicle is too small, the robot software really allows you to do that, and you can basically plan this long before you end up in the operating room. And so when you're in the OR and you've had all the screws placed, there's a significant amount of force that requires manipulating the spine. You can appreciate in the image and the inset all the way on the left. A lot of these screws are basically pretty far away from where you ultimately want them to end up, and so when you place that rod and you're bringing the spine to the rod, the degree of the correction and how much alignment you're able to get for this patient is really dependent on those screws, and that allows for significant correction and deformities. So for example, the scoliosis patient, the artificial intelligence software says we got a correction from 53 down to 19. Just looking at it, it looks like more than that, but that's what the algorithms have calculated. This patient, again, good coronal correction and good sagittal correction. Pelvic fixation has historically been the cornerstone of deformity surgery when you have long constructs. So if you're building a tall building or a multi-storied building, the foundation is the most important element. And so the same here in a lot of these big reconstructions. And so historically we've relied on iliac fixation for the lowest screw to get strength of our construct, because in a long fusion there's a lot of stress and strain against the lumbosacral junction. Well, the problem with iliac screws when you start them at the posterior superior iliac spine and terminate them in the cancellous portion of the ilium is that those screws are prone to windshield wipering, and so over time they can fail. There's a transition now to doing S2 alar iliac fixation screws because much of the purchase is iliac. You start along the sacrum between the dorsal foramen of S1 and S2, and the screw is angled inferiorly and laterally towards the anterior inferior iliac spine, and there's three portions of cortical bone: the sacrum that you've captured, across the SI joint, and the ilium where you terminate close to the anterior inferior iliac spine. The problem with S2 alar iliac screws is that they're much more risky to perform than a conventional iliac screw. So if you look at the posterior aspect, there's a risk of injuring the sciatic nerve and the pudendal nerves or the superior gluteal artery, and anteriorly the iliac vessels are at risk, or the sympathetic chain. Well, with the robot, these screws are a lot easier to place and with increased efficiency. So what are the advantages of S2 alar iliac fixation? Well, we talked about the increased purchase from cortical bone capture, but if you look at what the construct looks like when you use an S2 alar iliac screw, all the screws line up, right? So all the screws that go from the lumbar spine will line and run right into the ilium, which makes it easier to rod, and that makes MIS deformity now doable, because conventionally with an iliac screw, you needed a cross connector in order to be able to make the construct line up, which is very difficult if you're transitioning to a practice that does minimally invasive surgery. The other advantage of an S2 alar iliac screw is it's less prominent. It sits much more ventrally in comparison to where the posterior superior iliac spine is. And then an additional benefit is it restricts motion across the SI joint. So in many of these patients, when they have a sacral screw and an iliac bolt in place, they can still move through the SI joint, which can be a source of pain. So here's what planning an S2 alar screw looks like with the software. You can essentially start picking a starting point that's appropriate in the sacrum, and you can really get that screw point across the cortical purchase of the SI joint and terminate it at the strongest portion of the ilium, which is where the anterior inferior iliac spine is anteriorly. So in practice, what this looks like is, as all the other videos have shown, the robotic arm comes into place, and essentially that screw goes exactly where we want it to in real time, and the placement of the screw really takes seconds, and you know that that screw is placed precisely. And when you plan it with the software, you know where the head of the screw terminates And that really allows you to line that construct up. So here's what that looks like with the spine open. The S2AI screw is essentially in the field where you don't have to use a tailor retractor to get out to the PSIS, which is out here, where an iliac screw would be and needing a cross connector. So this all lines up perfectly, and obviously the patient's correction is dependent on that, so we're able to get good coronal correction in this film, and also restoration of their sagittal profile as well. Here's another patient, came into my clinic basically leaning to the right when she walks, obviously has significant thoracolumbar kyphosis, as well as coronal imbalance to the right. And again, all the screws end up where you want them to, and with the planning software, it makes rodding the construct at the end of the case, which can be frustrating, much simpler, because the heads of the screws are exactly where I want them to be, and the rod has already been pre-printed and specific to that patient. Here's another case, a double major scoliosis. Difficult to get correction in the sagittal profile when you're really focused on getting correction of the coronal scoliotic deformity, and obviously a good result for her. She did well, discharged from the hospital 4 days after surgery. So the accuracy of the robot is really precise and very unparalleled. If you look at the literature, the numbers that are being quoted there are somewhere in the range of 94 to 98%. So I think that with this tool, as with all tools, it's really a function of how you use it. I think it allows for more precise surgeries, and with many surgeries being dependent on where those screws are, it really allows you to get patients a much better result. One of my mentors used to say that all spine surgeries are deformity surgeries. Either you're fixing one or you're really making one because you're not fixing it the right way. This was when I was in training 10 years ago, and I'd like to think that we've come much further from this point of view with all the targets that have been established with the SRS Schwab criteria. In my practice, I think that a lot of getting patients into correct alignment is keenly focusing on the L4S1 segment. I think that's probably the most important segment in any fusion operation that involves that level. Why? Well, it's lower down in the lumbar spine, so the degree of correction that you get at L4-5 and L5-S1 has many folds changes in the lumbar lordosis, right? So it's the most effective segment for generating lordosis, especially in patients who have sagittal imbalance or a flat back deformity. Getting the correction right decreases the chances of adjacent segment disease, and that means less revision surgery. But it's also the segment that's under the most stress at L4-S1. So the segment of any long construct that's most likely to fracture is L4 to S1. So it's most at risk for pseudoarthrosis and instrumentation failure. And if you do scoliosis surgeries, the key to really getting the coronal alignment correct is paying attention to that lumbosacral fractional curve. Otherwise, the patient will be off one way or the other if you just straighten the main curve without focusing on the lumbosacral fractional curve. So L4 to S1, I think, is probably the most important segment to get right the first time around. Now, how you get the correction is highly variable. There's a lot of approaches to the inner body or to the disc space. Some surgeons may choose an anterior lumbar interbody fusion. The lateral approaches are also fair game, which include oblique lateral interbody fusion and the direct lateral interbody fusion, which includes XLIF, or the traditional approaches of a posterior lumbar interbody fusion or a transforaminal or TLIF. How much correction you get is not equal to the degrees of angulation that are on the cage, right? So if you put a 15-degree TLIF cage in there, it doesn't mean you get 15 degrees. Historically, if you study patients, a TLIF really only gets you 0 to 5 degrees of correction. If you look at laterals, XLIF or OLIF, you get about 5 to 10 degrees of correction. And an ALIF or an L5-S1 OLIF, which is really an ALIF in the lateral position, you get about 10 to 15 degrees, and you can do an anterior column release at any of the levels, and that will get you a little bit more. In my practice, a lot of what I do is laterals, especially OLIF, and I think there are a lot of advantages to the OLIF. I think the size of the cage you place is substantially larger, and so you can really manipulate the spine to where you want it. So here's a patient who is very flat, 2 degrees. We place a cage at L5-S1 in the lateral position, and you're really able to get 22 degrees, which would not be the case with a TLIF. Same, here's another patient. This is a case that was done single position, lateral followed by screws, and we really go from 14 degrees to 37 degrees. So you have a significant potential with lateral inner bodies to manipulate the spine and really get the correction that a patient needs, so you're not fusing them flat and forcing them to have a revision surgery in the future. Look at this patient, for example. So degenerative lumbar scoliosis. The power of the lateral is not just in the sagittal correction. Here's this patient. They had lateral inner bodies placed. And just with the cages alone, you're able to decrease the size of the lumbar curve from 24 degrees to 8 degrees before even placing screws. So the power of the lateral is it helps you not just with sagittal lordosis, but coronally, it helps you decrease the size of the curves, which is very important in a population, for example, where if they're osteopenic or osteoporotic, you don't really want to pull on those screws because obviously you won't be able to get the correction that's required simply because of poor bone quality. So this patient, we did some laterals, then did posterior instrumentation, and she obviously had a great result. Now, the other advantage of an OLIF is you can access any of the disc spaces from L1 to S1 from a single position. So in this picture, for example, L5S1 is through the small incision, and each of these incisions are about 2 to 3 inches, and we do them minimally invasive where we dilate through the muscle down to the spine. So you can do 5-1 through the most inferior incision and work your way up. And this, you can stage them if you choose to do that, but 3 levels of inner bodies will take you an hour typically per level. And if you get faster, you can get that level down to 30, 45 minutes. The natural transition, obviously, is if the patient's in the lateral position, 2 surgeons can work together, right? So it enables robotics in this context because with a lateral fusion, part of the hesitancy for many surgeons to use it is they need to switch positions, and they're obviously faster with a T-lift. Well, with the robotics, you have the potential to do this in a single position where one surgeon's working doing the oblique lateral inner body fusion, and the second surgeon is using the robot to place screws because, again, ergonomically speaking, it was very challenging historically to use navigation to maintain the position, especially on the screws that are on the upward trajectory, as we'll see in a second. The other advantage is you can use the robotic arm by sending it from the person placing screws to the person doing the inner body. The arm can swing over and you can use it as a guide to home into the disc space to perform the OLIF, which negates the need for you to take fluoroscopy in order to localize the disc space if you're doing a lateral surgery. So what does that look like? Patient's positioned laterally here, the robot's attached to the field. We then bring our C-arm in to use the coapter to basically correlate the intraoperative fluoroscopy films with the CT. And then ultimately, this is what it looks like. It doesn't matter what position you're placing the screws in, you can do that while the patient's in a single position and while your assistant or your second co-surgeon is basically doing the inner body stage of the procedure. These were the screws that were harder to place, the screws that were essentially in an upward trajectory, because if that patient wasn't at the edge of the bed, you didn't have the angulation to be able to place that screw. The robot essentially makes it substantially easier to place these screws regardless of the position that you're in. So here's a video from one of my colleagues who was able to use a GoPro to record the footage. One surgeon is placing screws, second surgeon is basically using the dilation system to get down to the disc space. This is all done minimally invasive because you don't need to see the entirety of the disc space, just the area that you have to do the inner body work at. The dilator comes in. The assistant on the other side is placing the screws, and altogether a single level will take you under an hour, right? So you really decrease the time that would be required to transition from lateral to prone to be able to accomplish this. And so together 2 surgeons work, it makes the procedure a lot more efficient. You can do 1 level. Here's an example of 1 level with percutaneous screws. You can do, here's another example in a patient. You can do 2 levels. And so the question becomes, if you can do 1 or 2 levels in a single position, well, can you do more levels? And I think this is where the robotics really becomes very useful. So MIS deformity was very difficult historically. In a deformity surgery, you expose the entire spine, you take all the muscles off the spine, and so you've really disrupted a key portion of stability, which is muscular attachment to the spine. Well, most patients or most individuals would say if someone has a scoliosis in the lumbar spine, well, that's a small price to pay for the correction that they get with screws and rods and the improvement in their pain. But is there a different way to do it? Can you do this minimally invasive? And I think this is where robotics is very helpful. Historically, there were a lot of challenges with deformity surgery. So the problem was you couldn't get good sagittal correction unless you really went open, did PCOs at every level, and manipulated the spine to where you wanted it to be. Well, with the lateral interbody solutions that we've looked at, you have the ability to really control the spine sagittally and to get however much lordosis you want depending on what the patient's mismatch is. The other problem with minimally invasive deformity surgery was, well, the iliac fixation was off midline. How are you going to place screws percutaneously and rod a construct when all the screws aren't in the same place? Well, S2 alar iliac fixation solves that issue because now all the screws will line up. So rodding that construct becomes substantially easier when you don't have to worry about malalignment of the screws. The next challenge was, well, how are you going to rod this percutaneously when you don't know where the spine is if you just have screw towers that were percutaneously placed? Well, you can prefabricate the rods with the artificial intelligence software. So now you have a rod that matches that patient specifically, and you know exactly where the screw heads are because the robots place them. You input that into software. And so you have screws placed, inner bodies helping you getting the sagittal correction, and now you can actually place the rod percutaneously. So the software really helps you. You can put towers on those screws, and you can go through and really plan where the towers of the screws will end up to facilitate easy passage of the rod through the muscle. And this was something that was historically very difficult to do because if you can't see the screws in a deformity surgery, then how are you going to be able to put the rod on at the end of the case if all the screws don't line up and they're not where you expect them to be? With the robotic software, you have the ability to do that. And so a lot of these patients who would traditionally have gotten a very large open surgery are getting minimally invasive inner bodies placed laterally for correction of the sagittal profile. So in this patient, for example, a lot of the lordosis is achieved through the inner bodies, and then you can actually rod this construct with the screw towers that come through percutaneously. So the conclusions of this are robotic-assisted spine surgery is a safe and effective tool for placing pedicle screws. It really allows us to do many surgeries in a single position, so you can skip the flip. You don't need to do lateral and then transition to the prone position. It really opens up this era now of minimally invasive deformity surgery where you can actually get correction simply through percutaneous placement of screws. And I think incorporating robotics, obviously there's a significant cost that goes along with that, but it's the same with any technology. You know, when flat screen TVs first came out, they were very expensive, and now they're everywhere. Same with cell phones. When they first came out, they were very expensive, not available to the general public, and not everyone could have it unless you had the resources. But with time and as more companies get established in the field, the cost is ultimately driven down, and this eventually becomes available to the entire mass. So I think initially there's a significant learning curve to incorporating this technology, but over time I think once you overcome that learning curve, it ultimately helps you to be more efficient in the operating room, and I think patients benefit better in terms of their improved quality.